So the next 45 minutes, I'm going to discuss a little bit about general overviews on type 1 diabetes, how to diagnose them, the pathophysiology, the complications, risks, and different types of therapeutic options. It's a lot to cover in 45 minutes, so I will do my best to get through all our slides here. All right, here we go. So there's about currently 3 million individuals with type 1 diabetes worldwide. However, the incidence rates vary by country, as you can see here. So for China, Venezuela, the incidence rates are extremely low. However, in Finland, neighboring countries, the incidence is generally above 64 per 100,000 per year. And globally, we see that the incidence of type 1 diabetes is increasing about 3% per year. 90% of childhood and adolescent diabetes in the Western countries are type 1 diabetes versus type 2. And about 75% of all type 1 diabetes cases diagnosed at younger than 18 years of age are type 1 diabetes, and about 10% of all adult diabetes are type 1 diabetes. So this was a really nice article in New England Journal of Medicine that looked at the difference, the incidence of type 1 diabetes versus type 2 diabetes. And I don't know if you can see my pointer here, but you see this is for those with type 1, this is for those with type 2, all adolescents from the age of, or younger, children 0 to 19 or 10 to 19 for type 2, and then stratified by race and ethnicity. And so you see for those with type 1 diabetes, the overall incidence is highest in non-Hispanic whites, which we know, lowest in Native Americans. And the incidence rates over this period of time from 2000 and probably is 2002 to 2012, those 10 years, the incidence rates are going up significantly in those who are non-Hispanic white and Hispanic as well, as you see here. Compare that to the incidence of type 2 diabetes in our youth, and you see kind of an opposite framing of the different race and ethnicity groups. So here, this is the Native American youth population, the dramatic increase in incidence in type 2 diabetes, as well as those who are non-Hispanic Black, compared to the lowest incidence group here is the non-Hispanic whites, and which are fairly stable and unchanging in the incidence, so newly diagnosed disease, compared to, again, the Native American and non-Hispanic Black youth population. So in brief, the pathogenesis of type 1 diabetes is very different than that of type 2 diabetes, as many of you may well know. The underlying disease process in type 1 is a complete loss of beta cell function, which leads to ultimately insulin deficiency. 90% of those with type 1 are due to T cell mediated, B cell facilitated autoimmune destruction, something we call type 1A. A much, much smaller percentage of those with type 1 have an autoantibody negative type 1 diabetes called idiopathic type 1, maybe type 1B, see more in ethnic and racial minorities in the US, African, and those of Asian descent. These people are prone to DKA. They do have permanent insulinopenia, meaning they do need insulin lifelong as well, but have a somewhat different underlying pathophysiology and pathogenesis of their disease process. We have now discovered many gene mutations that are associated and causal for type 1 diabetes. So 90% of type 1 diabetics carry the specific haplotype, the DR4-DQ8 or DR3-DQ2 haplotypes. 30% carry both versus 2% of the general population without type 1 diabetes. And then a combination of having both of these high-risk haplotypes confers an extremely high risk for type 1 diabetes with an odds ratio of 16, meaning they have a 16 times more likely chance of getting type 1 diabetes than those who do not. Something I think that it may be a bit more clinically useful for many of us is in terms of counseling our patients and their family members with what is their risk of type 1 diabetes, or what is the risk of type 1 diabetes in their family members if they have it. And so here you see some of that information. So if a mom has type 1 diabetes, then the risk of of having type 1 diabetes is about 2%. If the father has type 1 diabetes, then the risk in their child is 4.6%. If both parents have it, the risk of their child having type 1 diabetes is about 10%. If you have a sibling with type 1 diabetes, the risk of their sibling getting it is 3.2% throughout their adolescence and 6% for their lifetime. So what is really the underlying pathogenesis, kind of what triggers type 1 diabetes onset? It's really not yet clearly defined, although there's lots and lots of research looking at these various factors. So viruses, enterovirus being the most prominent one under studies, intrauterine environment, infant diet, whether you breastfeed or not, maybe even living in a colder climate might make you more prone to type 1 diabetes. But of course, all of these have yet to be studied in more depth to provide us a more accurate and precise answer. But lots of different theories out there. So from here on out, I'm really going to go through the American Diabetes Association guidelines, as well as some other guidelines specific for children and adolescents with type 1 diabetes, and looking at diagnosis, management, and complications. So first, we think about type 1 diabetes in terms of different stages of disease process. So stage 1, as you see here, means that a person has evidence of autoimmunity, and we'll talk about what that is, but yet has normal glucose measures, so normal glycemia, no symptoms of hyperglycemia, but yet they have more or equal to 2 autoantibodies. And again, no IGT, impaired glucose tolerance, or IFG, impaired fasting glucose on labs. Stage 2 is, again, you have autoimmunity, but now you have some evidence of glucose dysregulation. And again, no symptoms generally. So again, you have the presence of your antibodies, and now you have evidence of either impaired fasting glucose or impaired glucose tolerance after a OGTT, an oral glucose tolerance test, or you can also have some elevation in A1C in what we call the prediabetes range. Stage 3 is generally when we see patients present to clinicians and their providers with new onset hyperglycemia, and now they are symptomatic. And very standard symptoms that we think about with type 2 diabetes. So those with polyuria, polydipsia, they may even present with DKA. And the criteria to actually diagnose type 1 diabetes is the exact same as those with type 2 diabetes in terms of monitoring their glucose measurements, right? So you have a fasting glucose of greater than 126, a 2-hour postprandial glucose after a 75-gram oral glucose tolerance of greater than 200, or an A1C of greater than 6.5, or a random blood sugar of greater than 200. So all exactly the same as diagnosing those with type 2 diabetes. However, with type 1, you want to measure their antibodies to distinguish them as type 1 compared to type 2. And here's a list of different antibodies that can be measured. The most common ones that are measured in clinical practice are the GAD65 antibodies, the insulin autoantibodies, and then the islet cell antibodies as well. The zinc transporter protein typically and anecdotally is used in research settings. I personally have never ordered that for clinical diagnosis of type 1 in my practice. And then here's a list of the percentage of patients who have autoantibodies and develop type 1 diabetes. So as you can see when we talked about the different stages of type 1 diabetes, you can have presence of antibodies but not yet have actual disease onset or symptoms from the disease. And so here they looked at the percentage of people with GAD positive antibodies, and they followed them out. I believe this is in years, to look at how many people actually were diagnosed with type 1 diabetes. And about 70%, and they determined that there's a 70% risk for type 1 diabetes development within 10 years of antibody positivity, and 84% risk within 15 years of antibody positivity when looking specifically at the GAD antibody and the IA2A antibodies. And so let's turn now to how do we manage those who've been diagnosed with type 1. Oftentimes, we tend to see, as endocrinologists, we tend to see patients who've already been diagnosed by their primary care physician or been in the hospital and coming to us as follow-up with type 1 diabetes. So we'll go over, different things to screen for in terms of complications, glycemic control, and treatment options, including insulin, non-insulin agents, and potential transplants. So, as many of you may well know, the presence of having one autoimmune disease like type 1 diabetes confers an increased risk of having other autoimmune conditions such as thyroid disease, celiac disease, and some others. And so our American Diabetes Association guidelines recognizes this and recommends the assessment of the screening of other autoimmune antibodies, specifically thyroid and celiac disease, soon after the diagnosis of type 1 diabetes. With thyroid disease, about 25% of children with type 1 actually have thyroid autoantibodies at diagnosis of their type 1 diabetes. Does not mean that they are symptomatic or have overt thyroid dysfunction, but again, that they have a higher propensity to develop overt thyroid disease in the future. Thyroid dysfunction occurs more often in adults with type 1 diabetes and more often in women than men. And most of the time, it's typically due to hypothyroidism or Hashimoto's hypothyroidism versus hyperthyroidism. So only about 0.5% of those with type 1 diabetes have hyperthyroid disease. The screening test is with a TSH, a thyroid stimulating hormone, every 1 to 2 years sooner if they have symptoms. And certainly you can test them with thyroid peroxidase antibodies at diagnosis of type 1 diabetes as well, as recommended by our guidelines. For celiac disease screening, so about anywhere from 1 to 16% of individuals with type 1 diabetes have celiac disease, and that's compared to 0.3 to 1% of the general population without type 1 diabetes. The goal or the recommendation is to screen for celiac using these following lab measures, at the time of diagnosis for type 1 diabetes or soon afterwards. And if negative or normal, then repeat it at 2 years, again at 5 years. And then after that, it's a bit unclear. And so after 5 years of type 1 diabetes disease onset, the general recommendation is to screen them if you are concerned about any new symptoms, GI symptoms, or if they have other unexplained dysglycemia, such as erratic blood sugars that are not normal for that patient, or unexplained frequent hypoglycemia, again, a little bit out of the ordinary for that patient. And then, of course, the GI symptoms, some examples: diarrhea, weight loss, bloating, abdominal pain, malnutrition, malabsorption type symptoms. The lab testing that you get most commonly is the IgA and transglutaminase antibodies or anti-endomysial antibodies. If they have IgA deficiency, then you can also screen them with the IgG transglutaminase antibody and a deamidated gliadin antibody as well. So those are the celiac and the thyroid disease are the two more unique autoimmune disease monitoring and screening processes that you want to consider in type 1 that we don't really consider in type 2 diabetes screening and screening management. The remainder of the complication screening I'll go over is very similar to those with type 2. However, the timing and frequency are a bit different. So with nephropathy, generally you want to screen them for a urine albumin to creatinine ratio, but typically after 5 years of onset of diagnosis of type 1 diabetes. The GFR, the estimated glomerular filtration rate, can be assessed at the initial evaluation, and then continued if abnormal, continue to be followed and evaluated if abnormal. If similar to those with type 2 diabetes, if their albumin to creatinine ratio is elevated greater than 30, then at least 2 times in the span of 6 months, then you do want to start an ACE inhibitor, and if not tolerated, an ARB for nephroprotection. For retinopathy screening, again, it is recommended. However, it is recommended after about 3 to 5 years of type 1 diabetes onset. For kids, it's recommended to be done after the age of 10 or after puberty has started, whichever comes first. After that initial evaluation, then you want to follow them up with repeat retinal screens every 1 to 2 years as needed, or sooner as needed, if needed. And the thought is that retinopathy, unlike those with type 2 diabetes, whom you screen for retinal disease right at the diagnosis or at the very first visit, the thought is that with type 1 diabetes, the disease process of retinal disease hasn't actually started yet, compared to those with type 2, whom we think retinal disease onset has started at least 10 years prior to even being able to detect dysglycemia for those patients. Neuropathy, again, you want to do an annual comprehensive foot exam, especially for children at the start of puberty, or again after the age of 10, whichever comes earlier. And again, you don't really need to start that right away, but maybe after about 5 years of disease onset. And if you've noticed the E's on these, a lot of these are not based on actual randomized controlled trials, or even cohort studies. Most of these are recommended based on expert opinion. Cardiovascular risk factors, certainly a very significant aspect of screening and concern for type 1 diabetics. For children, you do want to start measuring their blood pressures, and if they're elevated greater than the 90th percentile, you want to start lifestyle diet management, or if they're actually hypertensive, so greater than the 95th percentile for age and sex and height, consistently, then you do need to start them on an antihypertensive agent. Generally, the recommendation is an ACE or an ARB as tolerated, even for children. For dyslipidemia, similar to those with type 2, we do want to monitor these fairly frequently. However, again, with type 1 diabetes, you don't need to do it until, for kids at least, until they're older than the age of 10, or soon after their glucose has been well controlled after diagnosis. The goal is, again, to keep their LDL levels less than 100, similar to our type 2 population. And as long as it is normal, you don't have to repeat it yearly, but maybe every 3 to 5 years is thought to be reasonable. In terms of treating our type 1 population for dyslipidemia, the recommendation is that you can start a statin safely after the age of 10 years, and as long as there's good counseling on preconception, as statins are teratogenic if female patients do conceive. And then again, the suggestion on when to start statin therapy for our young type 1 patients is if their LDL cholesterol is greater than 160, or if it's greater than 130 and they have 1 or more cardiovascular disease risk factors. And the goal of therapy is to keep it less than 100. And this may go a little bit against or differ from the newer AHA guidelines, but again, and some of that is in terms of clinical management will be kind of art of medicine and clinical decision making, depending on the provider and the patient sitting in front of them. So let's move on now to glycemic control. This is similar to, it's a similar way of thinking about and looking at how strictly to and stringently to control our type 1 diabetic patients in terms of A1C. So this comes from ADA's Standards of Care again from this year, which came out in January. And the goal generally for all non-pregnant adults with type 1 is to keep their A1C at 7% or lower. However, You can see lots of caveats here, and it's the importance has been to really take into consideration not only their comorbidities, but also their life expectancy, disease duration, risk of hypoglycemia or other drug effects, and again, the resource and social support and social determinants of health really that may affect one's overall well-being. And so, for example, I see patients here at Grady in our county hospital, and many of them really have very low resources available to them, low income. Their educational achievement may also vary, but if they're lower, and they're more prone to hypoglycemia, I may set their A1C target at 8% or maybe 7.5% or lower, really depending on what they're able to do. However, if you have someone that is overall fairly healthy, is young, fairly newly diagnosed with type 1 diabetes, no vascular complications, no comorbidities, you may be able to get their A1C down to 6.5% or lower, and as long as they don't have frequent hypoglycemia. So 7% is your general target, but again, you want to take into consideration all the various factors that go into an individual's health and overall well-being. So the main treatment for type 1 diabetes is insulin. So, and what type of insulin you use really is, at this day and age, determined by what insurance they have, unfortunately, or don't have for that matter. But you can use any combination of a longer or intermediate acting insulin, such as NPH, or any of these longer acting insulins, in addition to a rapid acting insulin, like Novolog, Humalog, or Apidra, or regular insulin as well. And again, this is just a listing of the main types of insulin we have on hand, the onset of action, the peak hour at which they peak, and then the duration of their action profile, just for your reference. It's available in the Diabetes Care article in 2018, if interested. I also wanted to just show, and I know this is a bit small, but just show you the different prices of insulin in the US currently. And this has become a big issue in the last 6 to 12 months or so, trying to become more transparent with the rising cost of insulin and the inability or difficulty our patients have in affording insulins, which are life-saving for our type 1 diabetics. But you can see here, this is the average wholesale price listed here, and the median price that our patients are paying for them, and the many different types of insulins and the growing number of insulins really that we have currently. NPH and regular, the two human insulins, the oldest types of insulins we've had on the market, are the cheapest. And I believe, I don't know in other states, in Georgia, 70/30 and NPH and regular are available even without a prescription at all Walmart pharmacies for $25, $27 a vial. So that is always available, typically, and accessible to most patients. I've even had a few younger type 1 diabetic patients who graduated from their pediatric practice come to see us here at Grady after being out of care and lost to follow-up for 5-7 years, and they've been able to just maintain their diabetes without going into DKA by getting over-the-counter NPH and regular, which is a little bit scary, but in some ways has been life-saving for those individuals as well. Okay. So you have a type 1 diabetic patient in your practice, you've just diagnosed them. How do you start them on insulin if you don't have access to an endocrinologist or a CDE right away? So I'll go over kind of the titration or the calculation that we use. Generally, I did want to put up here the recommendations for a continuous glucose monitoring system and frequent checking of your blood sugars as recommended by ADA. So CGM, continuous glucose monitoring, should be considered in all children and adolescents with type 1 diabetes, whether they're using whether they use subcutaneous injections, multiple daily injections, or insulin pump therapy as an additional tool to help improve glycemic control. The benefits of actually having a CGM is really related to their ability to actually use it, right? Which makes sense. All children and adolescents with type 1 should have blood glucose levels monitored multiple times a day. So many of you may struggle similarly as I do with getting your patients to even monitor their sugars 3 or 4 times a day before meals. But with type 1s, it's really recommended that they need to be checking 6, sometimes to 10 times a day, including pre-meal, pre-bedtime, sometimes overnight for safety if they have overnight hypoglycemia, and then if they have any kind of different or irregular activities going on, like exercise or illness or any symptoms of hypoglycemia. So it's a lot. It's a lot to ask of our patients and their caregivers if they're kids, which is why I think the recommendation for a continuous glucose monitoring system has become so strong in this population specifically. So how do we start insulin? Many of you may already know this, but generally we use a target of using for their total daily dose, TDD, 0.4 to 0.5 units per kilogram per their weight, per kilogram per day. And so I have an example here for you. I find that that's the easiest way to learn. So for a 70 kilogram patient, you do 70, I use 0.4 for this instance. So do 0.4 times 70, so their daily dose of insulin will be 28 units. Their basal insulin, you split this 28 unit number by 50%, so half of it should be a longer acting insulin like Levemir, Orlantus, or Tresiba. And then the other 50% will be used for their bolus insulin divided into 3. So for this instance, you do 14 divided by 3, which comes to about 4.6 if you have a pump, or 5 units per meal. And this is kind of a very general way of starting insulin. You can do this for your type 2 patients as well if you are starting them on basal bolus therapy. The ideal way for a type 1 diabetic patient ultimately to control their blood sugars is really to use an insulin to carb ratio, either through an insulin pump or just manually being able to calculate this on a day-to-day basis. And so that's really talking about learning how to carb count. There's lots of apps and books out there now to teach patients and their caregivers on how to do this. And certainly if you do have the resource, they do need to see a nutritionist or dietitian to help them kind of learn how to do this and continue to hone their skills in carb counting. And so, because it's very hard to eat the same number of carbs for every meal or every snack, and especially with young kids, it's almost impossible to do. So the insulin carb ratio is really saying for every however many grams of carbs, you need 1 unit of insulin. And this insulin to carb ratio number may change really depending on the patient's personal insulin resistance or insulin sensitivity, and also what's going on. So if they're going to exercise right after they eat, you might want to give them a little less insulin. So you might say, before exercise, just do 1 unit for every 30 grams of carbs instead of 15 grams to prevent hypoglycemia before exercise. So, having a patient that is able to carb count appropriately and reliably is, I think, a game changer for a lot of our patients. So outside of insulin, what are some options? What's been studied? So a lot has been studied, especially our SGLT2 inhibitors seem to be a big hit in terms of potential benefit for our type 1 patients. But right now, the only approved non-insulin therapeutic agent for type 1 adults, not kids, but adults, is Pramlintide, and we'll go over some of that data. For kids, unfortunately, there's insufficient evidence to support any routine use of adjunctive medical therapies, as I mentioned before. So Pramlintide is an older medication. It's an amylin analog. So amylin is a hormone that is endogenously, naturally secreted in by our stomach. It delays gastric emptying, blunts glucagon secretion, and enhances satiety, so you get full quicker. It has been shown to decrease weight, so 0.4 to 0.5 kilograms, or about, almost a pound, 1.5 pounds. It can slightly decrease your A1C as well, 0.3 to 0.5%, and it can also decrease the total daily dose of insulin needed for our type 1 diabetic patients. It is an injectable therapy, so it's additional 3 injections a day, which is probably the main reason why it's not as widely used currently. And it does have some GI side effects, as well as increasing the risk of hypoglycemia. But it has been FDA approved and is available for adjunctive therapy in addition to insulin for our patients, our type 1 diabetes adult patients. So the SGLT2 inhibitors, many of you may know, these are our newest class of drugs used for type 2 diabetes, type 2 diabetic patients. It has been studied in type 1 diabetic patients as well. And we have a growing number of different brands of the SGLT2 inhibitors. I've listed here some of the bigger studies that have been done. So dapagliflozin was studied with a DPIC study, the sotagliflozin, which is a bit special in that it inhibits both 1 and 2 receptors, SGLT2 receptors, was studied in tandem 1. Empagliflozin was studied in the E studies. I'm just going to give you the summary for most of these studies, and many of them have ongoing longitudinal follow-up that's pending. But overall, they do improve A1C by about 0.4%. So, you consider whether or not that's clinically significant for your patient. It does decrease weight about 3 kilograms, so about 7 to 8 pounds. There's no increased risk of hypoglycemia. However, almost unanimously in all of these studies, there is an increased risk of diabetic ketoacidosis in the type 1 population, and specifically euglycemic DKA, meaning their blood sugars may not be sky high, maybe just in the 200s or even lower, and they still become ketotic. So certainly the risk is something you need to discuss with your patients and talk about. If you do decide to use this agent in type 1 diabetics, talk about screening more frequently for ketones. So the other agents that have been studied are the GLP-1 receptor agonists. So this is like your exenatide, liraglutide, those types of agents, the once-a-week injections or the daily injections. And again, overall, there has been shown some decreased weight, some decrease in A1C, about 0.2%, some decrease in the amount of total daily bolus insulin needed, so your mealtime insulin needed. There is an increase in GI symptoms as we see in type 2 diabetics, and again, no increase in hypoglycemia. With the GLP-1 receptor agonists and the SGLT2 inhibitors that I've discussed, they are not currently FDA approved for type 1 diabetes use at this time. The DPP-4 inhibitors that have been studied include sitagliptin and vildagliptin. And similar in terms of their effect, they really don't have a huge effect, but might favor decrease in A1C for those using that. And let's see, this is sitagliptin. So it looks like it's somewhat differing results using these agents. So again, not currently FDA approved for type 1 diabetes use. Metformin has been studied many times for type 1 diabetic patients, especially those who do develop some degree of insulin resistance and show that when they become overweight or obese. Most of these studies are negative. They do show some weight loss, but not significant decreases in A1C or need for total daily insulin dose. So we'll move on now to transplants. So who is eligible for pancreatic transplant? Typically, this is kind of our last-ditch effort in trying to control a patient with type 1 diabetes. We generally don't recommend doing pancreatic transplants by itself, but to do them together with kidney transplants. And so typically we recommend it if they have late-stage kidney disease, they have hypoglycemia unawareness, meaning they have absolutely no symptoms, even if their sugars are dropping down into the 40s, sometimes 30s and lower. And and they have unstable glucose control with a very large glycemic variability, meaning they can be 300 and 50 on the same day, so very high glycemic excursions. The different types of pancreatic transplants are listed here. You can have a simultaneous pancreas and kidney transplant, which is the most favorable and recommended of the three. These transplants tend to be functional for an average of 9 years, so take that into consideration when thinking about this for your patients and and how much longer that you think they have to live. Pancreas after a kidney is available, and these organs tend to be functional for an average of 6 years. Pancreas transplant alone is available. However, we rarely advise or recommend it. It's only after we exhaust all other treatment options. Again, functional for about an average of 6 years. And keep in mind that with all of these transplants, patients do need to be on immunosuppressive therapy lifelong for graft function. Islet cell transplantation was a bit more, people were excited about this a lot more maybe about 10 years ago. Currently it's experimental. It's for people who really have absolutely no other option, who've even tried whole organ transplants and have failed or have had graft rejections. In some of the cases, we have seen that patients can become normoglycemic after an islet cell transplant without the need of insulin for an average of about 3 years. But the majority of patients do need to restart insulin. However, they do have less hypoglycemia and less complicated regimens. But again, currently it's only under research protocols and experimental. So I'll end, I think we only have a couple minutes left, but I'll end with kind of how we're doing as a country. And this is US data looking at a large cohort of people with type 1 diabetes. And as you can see here, the majority of this cohort are non-Hispanic white as representative of the general population. And it looked at a lot of different variables, how many, what percentage are using insulin pumps, DKA episodes and such. I just wanted to highlight our glycemic targets and how we're doing in terms of getting our patients down to kind of the standard goal of 7% and A1C of 7% or lower. This is stratified by race. And as you can see, we're not doing a great job. The average A1C for type 1 diabetics who are non-Hispanic white are 8.4%, those who are non-Hispanic black, 9.6%, and those who are Hispanic, 8.7%. So there's some differences between the races, perhaps some disparities due to other factors. But again, there's certainly room for improvement. I've listed here some important studies and cohorts to keep an eye on. So DCCT edict is a very old study. The DCCT, I believe, started in the 1990s. I want to say, I can't remember off the top of my head. An edict is the follow-up cohort. Steno2 Surge, the Today study. Type 1 diabetes exchange is a registry of many type 1 diabetic patients in multiple different centers around the states. TrialNet, which is looking at antibodies in family members of those with type 1 diabetes and the incidence of actual disease onset. The DAISY study and the TEDDY study are also fascinating studies to keep an eye out for in terms of their new publications and findings. A list of references I'm happy to share if you like, and I believe that is all I have. I'm happy to answer any questions here for the next few minutes, and if not now, then feel free to email me at the email below for any questions. Thank you very much for listening.